Greeting and thank you for joining us today. My name is Amir Lerman. I'm the Vice Chair for Research for the Cardiovascular Disease in the Mayo Clinic. And I have a pleasure to introduce my colleague, Dr. Joerg Herrman, Assistant Professor of Medicine, recently joined our staff and currently heading the effort for the establishment of the Cardioncology Clinic. Thank you for joining us, Joerg.
Thank you, Amir. It's a real privilege. Thank you for having me.
So, we would like to talk about an emerging problem that we see with our population, with specifically the aging population, that the patient that have cancer not necessarily are dying from their cancer, but actually living with the cancer and facing cardiovascular disease and event. And I would like to, for you to again tell us what's the need of this clinic and how did you planning to see the future of this kind of a clinic?
Well, actually, theheart.org, commented on this way back in October of 2010 with a headline saying, new discipline of cardioncology is evolving as cancer patients now live longer. And this is what you're implying. And when we look at the statistics, it's quite impressive. 5-year survival rates for cancer patients used to be 40–50%. Now we're talking 70%. There are even some cancer processes, malignancies, such as Hodgkin's lymphoma, breast cancer, prostate cancer, where we see 90+ survival rates, 5-year survival rates. So this is quite staggering, and this is really has introduced a change of mindset, what you're implying to. And this is really what generated the need for the field. And
yeah, so when you look at the need of the field, we can see that there are several aspects of the need of the field. The first one, of course, is to, as you mentioned, to have the patient or the individual with the cancer live with their cancer and not face any cardiovascular event. But one challenging area that I see that I would like you to comment is that the cardiotoxicity of the new chemotherapy and how we can identify or screen the patient prior to the chemotherapy. Who, in your opinion, what kind of method should be developed to assess the risk of this patient?
Well, this is an evolving field, and the antibody-based therapies, the breast cancer patients that really initiated a lot of this. And there are a couple of guidelines that have come out as far as overall assessment. It's clinical, first of all, history and physical exam, and then the ECG and echo has really been a central part of it. And so these are the baseline assessments of these patients.
Are there any specific parameters of the imaging and the echo that are more helpful for you to assess the patient?
Well, the American Society of Echocardiography will come out with recommendations for strain imaging for the detection of chemotherapy-related cardiotoxicity, I believe even this year, which is really an important move. It's going to be important for clinical practice, but also will have implications for clinical trials. And it has been driven by the discoveries, not only these breast cancer patients, but other collectives, where we see that strain imaging detects an abnormality way before the standard echo parameters do. And early recognition and treatment really has been key for overall restoration of cardiac function and improvement of patient outcome. And it's staggering and saddening in a way to see some papers being published that patients are not treated not only not in time, but not adequately at all.
What do you estimate the risk in general of having any cardiotoxicity of the new chemotherapy drug for breast cancer, prostate cancer, colon cancer? What are the numbers that we're talking about?
Well, we're talking numbers as high as 30%, but people have gotten a little bit more, have gotten more gray hair over this, as we get, wiser and wiser as time is going by. So we realize, what risk factors there are. For instance, extremely young age or extremely old age, hypertension, any prior underlying cardiovascular disease condition essentially is putting the patient at risk for collateral damage.
Well, what are the consequences of having this cardiotoxicity? I understand that it's not very innocent disease.
Well, there are some prominent figures which have identified two types of injuries, those that are reversible, others that are not reversible. So if we're talking about the classical, the anthracyclines, that's what everyone is thinking of, prominent publication in New England in 2000 showed that anthracycline-induced cardiotoxicity or cardiomyopathy is actually one of the worst of all cardiomyopathies. There's patients, half of them not making it up to 2-year survival.
Do you think there are a need for guidelines to how to screen and how to identify patient risk for chemotherapy, and how do you interact with our other disciplinaries to work on these programs?
Yeah, so I mean, it's really, I mean, that's what you need. You need a group of committed colleagues who like to interact with the oncologists and hematologists. And the way we do it is just an open, frank discussion. I mean, we have joint meetings, and we also, I mean, on a regular basis review cases. And whenever they have a question, they approach us. And now we've come up with our e-consult mode. But also, I mean, this is a face-to-face interaction as well. Other institutions do this as formal consultations and actually have the oncologist and the cardiologist see the patient together.
And just the last thing is that if you can touch about potentially more mechanistic, common mechanism of these two diseases, just in 1 or 2 words, what are you working on the common mechanism of that?
Well, I mean, there's, I mean, one prominent, I mean, one is, I mean, that relates to angiogenesis, and we've seen, I mean, like smoking. I mean, it's bad, although others claim it is not, but it's bad for the cardiovascular system and obviously for cancer. And one mechanism really is the angiogenesis. And we've seen, I mean, you've published, I mean, we've published on this as vasovasorum neovascularization, plaque neovascularization, and it is a driving factor. Other factors such as obesity with caesars with colon cancer, as in cardiovascular diseases. I mean, there is a number of joint mechanisms on the vascular wall.
Again, Joerg, thank you very much for joining us and sharing with us this insightful information about this new entity. And again, thank you very much for joining us, and greeting to all.